Good afternoon. It's Wednesday, February 21st, 2024, and this is a Protect Our Province live briefing on long COVID. I am Dr. Susan Coe, a family physician who has been working in Richmond, BC for 31 years, a clinical associate professor at UBC, and a member of Protect Our Province BC. Protect Our Province BC is a nonpartisan, nonprofit grassroots organization consisting of doctors, nurses, health scientists, and community advocates striving to keep the people of British Columbia safe by sharing accurate information about COVID-19. We begin by respectfully acknowledging that we are broadcasting from the traditional, ancestral, and unceded territory of the Coast Salish peoples, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. We're grateful to the Indigenous peoples who have cared for this land since time immemorial. As settlers, we commit to do our utmost to uphold the Truth and Reconciliation Commission and work towards the 94 calls to action. Today, we are joined for a live briefing on COVID and the heart by Dr. Leslie Kasza. Dr. Kasza graduated in medicine from the University of Western Ontario. His training took him across Canada. He did 2 years of internal medicine residency at McGill, then took a 1-year break to work in ERs across southeastern Ontario before finishing his internal medicine residency at McMaster University. Dr. Kasza did his cardiology specialty at the University of Alberta and followed this up with echocardiography or heart ultrasound training at both U of A and UBC. Dr. Kasza has been practicing cardiology in Alberta for over 30 years. Dr. Kasza, thank you for joining us today to talk about COVID's impact on the heart. Just to be clear, we will only be focusing on adults as this is where Dr. Kasza's experience lies. We also want to be clear that Dr. Kasza and I will not be providing any health recommendations, but discussing the current data about the cardiovascular impact of COVID-19. So we're going to start a discussion about the impact of COVID on the heart. So Dr. Kasza, how has your cardiology practice changed since the COVID-19 pandemic began with respect to the conditions patients are presenting with?
First of all, thank you, Dr. Coe, for having me, as well as thanks to Protect Our Province BC. What has happened since the pandemic has started is that volume of patients have gone up, as well as it's a very diverse group. Whereas before I was seeing a smaller number of folks that were typically older and had other medical conditions. Now I'm seeing younger folks that were previously reasonably healthy, and my older stable patients have gotten sicker. I think that it runs the gamut of both cardiac and vascular conditions, which include coronary artery disease, arrhythmias, myocardial or heart muscle disease, as well as significant peripheral vascular disease and arrhythmias. So it really runs the full gamut, and things sometimes you wouldn't necessarily expect, as well as large and small vessel disease.
Can we have slide 1, please? So Dr. Kasza, can you comment about the average age of patients being referred to you? Has that changed?
It's the first thing I will say is that, I noticed initially, probably in the first year or two, that I was seeing a lot younger patients, people that were under the age of 50, 45 and 50, with many different conditions. As you can see on this slide, there, stroke and TIA I don't see directly, but I often get asked to comment on the source of embolism. Cardiac rhythm disorders, quite significant. Inflammatory heart disease, we've seen more of. Ischemic heart disease is just disease of the arteries that supply the heart, the coronary arteries, and numerous other cardiac conditions. Heart failure in particular, I'm actually surprised at the study because in my experience, I've seen a lot more of them, and clotting or thrombotic disorders have absolutely gone way up. The other thing that's happened is not only are you seeing it in younger, previously healthy people, but in older patients, in those that have stable heart disease, especially after 1 to 2 infections, they've gotten quite sick, and their heart function's deteriorated, and they've presented with numerous problems.
Yeah, it's very concerning. And so how busy is your practice now compared to before the pandemic?
While it was busy before, it's incredibly busy now. There's lots of work to do. The people I see on average, particularly in the older age group, are quite sick. They have to be monitored more carefully, more frequently. And I'll be quite honest with you, it's been a very humbling experience because if people are unwell, you got to go hunting for things that maybe you wouldn't necessarily have considered. In particular, deep vein thrombosis and pulmonary emboli. I don't think I ever saw so much in
Mm-hmm.
25 plus years as a cardiologist as I've seen sometimes in 2, 3, 4 months. And there's other medical conditions I've seen an awful lot of. And as far as rhythm disorders are concerned, atrial fibrillation is it's all over the place. But not only the fast heart rhythms, I've also seen evidence of slower heart rhythms,
Mm-hmm.
including people who require pacemakers. So we're really seeing the whole gamut of cardiac and vascular disease, and there's much larger numbers, which makes certainly me and all of my colleagues very busy.
Yeah, I totally agree. In family medicine, and my practice has been just so much busier, like astronomically so. And now I'm seeing people with heart attacks at a much younger age group, more people with these irregular heartbeats, arrhythmias, more people with high cholesterol, and more cases of heart failure. So I totally agree. So, Dr. Kasza, what are the most likely mechanisms for how COVID is affecting the heart?
I think there's a number of mechanisms. I think the one that's been talked about quite significantly is the whole issue of SARS-CoV-2, the virus that causes COVID, being an airborne vasculitis or significant vascular disease where it infects the endothelium directly, and there can also be immune effects. You can also see either direct infection of either the myocardium or the blood vessels, as well as autoimmune causes. And these secondary effects can also occur. The difficulty with SARS-CoV-2 is that it infects numerous types of blood vessels directly. But the issue is that if you have vascular or involvement of the lining of the blood vessels, all organs in the body need blood. So all major organ systems in the body are significantly infected. In addition to sort of any direct infection or direct autoimmune effects, there's the chronic inflammatory effects, so that COVID itself, SARS-CoV-2 itself is likely a risk factor, and it magnifies other risk factors, in particular
Mm-hmm.
high blood pressure, as well as high cholesterol. So there's numerous mechanisms, and I could dig deep into the woods and talk about the subcellular effects and the autoimmune effects, which neither of which I'm an expert in. I'm sure we have people listening that know a heck of a lot more about that in their little finger than I will ever know in 100 years. But there's many mechanisms. The ultimate conclusion of it is that there are many mechanisms, and it's clearly had quite a significant effect.
Mm-hmm. So maybe we can take away slide one, and we're going to move on talking about the consequences, explosion of heart disease post-COVID. So since the pandemic started, more people are now dying, often at a younger age, and there appears to be more deaths than levels seen pre-pandemic wise. Can we have slide 2 now, please? So if we can have slide 2. Maybe,
We're there.
are we there? Okay,
Yeah.
here we go. All right, so slide 2. So this slide is from the Insurance Collaboration to Save Lives. So Dr. Kasza, could you comment on this slide?
Well, I think the biggest thing that's apparent to me is that, as compared to 2019, there's increased death rates by comparison. The most prominent is in the sort of 15 to 49 year age range, although it gets a little better as as we go further along. But there's still in that 15 to 49 age range, there's fairly significant excess death rates, and of course, it
Mhm.
starts to drop off, and then goes back up again in the older age group. So, I mean, the thing that stands out to me as you go along is this big 30-year age range in the early and mid portions of life, and then of course
Mhm.
the end of life.
Yeah, it's very concerning. Now, how much of this do you think it's due to COVID's impact on the heart?
I will preface my remarks by saying that what I'm about to say is speculation, although I think it's speculation backed up with both some observation and some clinical work. I think that a lot of this could be due to sudden death, either myocardial primary myocardial disease or arrhythmias. And in addition, if you have a very significant burden of clot in the lungs, or submassive or massive pulmonary emboli,
Mhm.
as well as a significant stroke. Those are the things that sort of occur to me. And in addition to this, would be any sort of damage to major vessels, like an aortic dissection, where the lining of
Mhm.
the vessel wall of the aorta, the big artery that
Mhm.
supplies blood to the body, tears. So it could be any one of a number of things. It also could be other things as well.
Now, can we have slide 3 now? Okay, great. So, Dr. Kasza, this is another slide from the Insurance Collaborations to Save Lives. Can you comment on this slide, please?
I think the left side, as I'm looking at it, the left side where it says, as COVID and some related causes declined in 2022, you can see heart disease is starting to go back up again. Cancer seems to have flattened and is starting to move back up again. And I'm thinking to myself, that's very interesting.
Mhm.
And then on the right side, you see that things like stroke, diabetes is going up, kidney disease, liver disease are all going up. Just as an aside, many strokes are due to blood clots or thrombi. So if you have a situation where there's an increased tendency for the blood to clot, obviously you might expect more as far as as far as more strokes are concerned. Diabetes is interesting for two reasons. One, because SARS-CoV-2 can affect the pancreas, you know, mostly immune mediated, possibly some direct infection.
Mhm.
If you have a damaged pancreas, the risk of diabetes is going to go up. And the problem with diabetes is it's also a cardiac risk factor as well as a kidney risk factor. So you've got kidney disease and liver disease that they're largely flat, but my suspicion is that as the years go by, they may also go up as well. So there's a lot of different things going on, and I think that SARS-CoV-2 is contributing to these things more than people realize.
Now, earlier this week, we were having a very interesting conversation about the parallels of COVID with the 1918 influenza pandemic. Can you tell us about that?
There's some long-term data from at least one paper, and there might be more than one, that suggests that the risk of cardiovascular death was quite high in the first 40 to 45 years after the 1918 pandemic. And interestingly enough, death from heart disease started to drop in the late 50s and early 1960s, even before people started to cut down on their smoking. And
Mm.
what I think is interesting about that is this: it suggests that a viral infection of the magnitude that we saw during the pandemic may induce a chronic inflammatory condition. And hardening of the arteries, or atherosclerosis, inflammation plays a significant portion in cell wall damage. And
Mhm.
then, as you got along, a lot of the people that were survivors of the 1918 pandemic, after 40, 45 years, many of those people died out, and you didn't have as many people around that, had been directly exposed to the virus at that time. The other thing that sort of supports that a little bit is that it's well known that during an outbreak of influenza that carries on for a while, some people will there will be more heart attacks, and there can be more death from heart attacks during an influenza outbreak as well. So it suggests that, and I also know, just as an anecdote, that I worked with a brilliant colleague long time ago, 35 plus years ago, who had developed an avian or chicken virus model of chronic inflammation.
Mm-hmm.
A lot of people poo-pooed her at the time. I have to say that she was almost prophetic in what she predicted, and I think a lot of those things are very consistent in what we're seeing now. Now, what I'm saying here, some of it is speculation, some of it has some evidence to back it up.
Mm. So maybe we can take down uh, slide 3, please, and we're going to move on to discuss what people need to do to avoid COVID-related heart disease. So, Dr. Kasza, now that we know that COVID infections affect the heart, what should people who have been infected look out for?
I mean, I think the major things that people have difficulty with after COVID, and after COVID infections that might signal some problems with heart disease include chest pain, particularly with exertion, or even not with exertion, worsening shortness of breath, if they get dizzy or lightheaded, if they notice that they have long episodes of a rapid heartbeat, or palpitations where they have intermittent or regular heartbeats. If they've had episodes where they've almost passed out, obviously, I think all of those things need to be looked into.
In people who've recovered from a COVID-19 infection, what screening investigations would you recommend they consider asking for?
This is a big and a loaded question. I think as far as blood work is concerned, the first thing is that I think basic screening things that I think should be included would be a CBC, sort of a differential. And I think if people's lymphocytes are low, it's lymphocytes, which is a type of white blood cell, are low. That should be looked into further. That's an area that obviously is beyond my expertise. I think it's important to know what your blood chemistry is like your electrolytes and your kidney function as a baseline. I also think liver function is important. I personally think a C-reactive protein, which is a measure relatively new, and I've been around for a while, measure of inflammation in the blood. I also do think that checking thyroid function is useful because of the risk of autoimmune uh, conditions. A so-called D dimer, which may indicate a tendency towards clotting, I think is very much a judgment call. One of the things that came up in some studies that were done out of Yale by the brilliant Professor Iwasaki indicated that not cholesterol, but cortisol
Mm.
abnormalities became important, and to have a specific test that looks to see whether or not cortisol is affected is certainly helpful. Obviously, I think a lipid panel, a cholesterol test is important. And many people post-COVID whose cholesterols, for whatever reason, start to go sky high. And, they're in folks with otherwise, no risk factors. Obviously, the other thing that I think is important as far as examination is concerned is look at the trend of what people's
Mm.
blood pressure is like, because many people have problems with higher blood pressure post-COVID. And guess what? High blood
Mhm.
pressure and high cholesterol are risk factors for cardiac disease.
Mhm.
Of course,
Uh,
and blood sugar, because as I've mentioned before, diabetes is something we see more of post-COVID as well.
yeah, that's a good point. Definitely seeing more of those cases. So, how soon should someone resume exercise after having COVID-19 infection, both in the general population, general public, versus athletes?
You'll notice that Dr. Koh is asking me very easy questions today. That one's tough, and I'll tell you why. My general my general view, if somebody asks me about that, is I ask them to to go easy, certainly for at least a few weeks, and to build up gradually and slowly. I don't want I ask patients not to push themselves to the maximum, to try and get to a point a little below where they are, because there's a condition, particularly in people that have extended symptoms, or so-called long COVID, called post-exertional malaise, for which there's a lot of mechanisms. There's, reduced oxygen extraction. There may be a cardiac component to it. We now know that, from some recent studies, that there's actual muscle abnormalities that
Mm-hmm.
cause difficulty. So my advice to people is, take at least a couple of weeks off, start very slowly, with walking, and sort of gradually build up. But I ask people not to go, not to push themselves to their maximum, which in the endorphin junkie so-called athletes in their 40s and 50s is often very difficult to do. And it's almost verbally, you kind of have to hog tie them to get them to sort of not go as fast. Athletes, I'll tell you, is tough, because I think high-level athletes or professional athletes, you're almost bound and determined to do more investigations, which include imaging investigations, cardiopulmonary exercise testing. But again, I think with those individuals, going slow and gradually working up to submaximal exercises is very important. I think, as a number of people know, I think it was Brent Suter
Yes.
who played for the Vancouver Canucks at the time. He took an extended period of time off, as well as, of course, Jonathan Toews, who's the captain of the Chicago Blackhawks, who's tentatively retired right now. So for professional athletes, it's significant. Of course, we've had some soccer players who have unfortunately had cardiac arrest, some of whom have passed away. So in general, as far as advice for exercise, it's basically take it slow and just go to the submaximal level. There's a number of people. The most prominent one is David Petrino, who's from Mount Sinai in New York, and a number of other people who talk about this. Not to push it, and to be aware of this so-called post-exertional malaise, which is a significant feature of long COVID and other sort of post-viral syndromes as well.
Thanks for answering that tough question. So after COVID-19 infection, is there anything else you'd recommend people do to prevent COVID-related heart disease?
Yeah, there's three things more than anything else. If you don't get infected, if you get infected, don't get reinfected. So the three most important things are: wear high-quality masks in high-risk situations, indoors, and outdoor gatherings where there's a lot of people around. Ventilate your workspace and home space, and make sure you filter make sure you filter the spaces as much as you possibly can. Although there's some debate about it in the general public, I think that FRCPC has accepted the fact that this is an airborne transmitted virus, whether you want to call it a vasculitis, whether you want to call it a respiratory infection, whether you want to call it a body nastyitis, and you must act to mitigate things in those three areas that I mentioned. The other thing is get vaccinated appropriately when the time comes to protect yourself. And if you have symptoms, make sure you get investigated. And the degree of investigation is obviously going to depend on symptoms. I think that the medical profession as a whole has done patients, and unfortunately ourselves, a great disservice by minimizing and psychologizing a lot of people's complaints. And I think, for me personally, I found that I just sit back, I listen, I make sure that if I'm not happy about something and I need to chase things down where I need to do more specialized testing, I go ahead and do so. So I think anybody who's having significant symptoms, they should be investigated.
Yeah, I totally agree. And Now, while we're putting up slide 4, can you tell me, Dr. Kasza, you're seeing patients in your office now. What kind of precautions are you taking to keep yourself and your patients safe from COVID and other aerosol spread viruses?
Well, full disclosure, I am in my office. The door is closed. My window's open. That little piece of paraphernalia in the lower right-hand corner is a HEPA filter, which is running. We have, I think, 6 or 8 HEPA filters running in various rooms in our office. I wear an N95 equivalent mask or higher, as does my staff. I ask patients to wear masks, and there are HEPA filters in each of my examining rooms to try and reduce risk. The other thing I tell patients is that if you're not well, if you have a cough, you're sick, you have the flu, stay home for a couple of weeks. We promise we will see you. So that is an issue of trust. And if somebody's not well, I basically, oftentimes I'll phone them myself, check on them, and say, "Get better. We'll see you in a couple of weeks, and make sure you're okay." But that's an issue of trust and give and take in the relationship. So those are the things that, as a general rule, that we take for granted. And yes, I do wash my hands. And yes, we clean stuff up appropriately. But that's just good, hygiene. But with an airborne virus that's this infectious, I think the things I've mentioned are very important to try and minimize the risk of infection.
Yeah, I could not agree more. I have exactly the same setup as you. I wear N95 masks. We have HEPA filters throughout our entire office. HEPA filters running in the background of my office right now. And that's the only reason why I'm not wearing an N95 mask in this room. Could we have slide 4 when you have a chance? So is there anything else? Sorry, slide 5. Is there anything else that you wish to add that we did not cover?
Well, I think, as you saw on slide 4, you don't want to, if you get infected once, you don't want to get reinfected, because one infection carries at least a 10% risk of getting, long COVID symptoms. 2 or more infections, things start to go up quite significantly. The other issue, and that's shown on slide 5, is that there's this almost myopic tunnel vision focus on the first 30 days post-COVID infection. Ladies and gentlemen, the fact of the matter is, the real risk of this virus is not just in the acute phase, where between vaccination and some other treatments, we've managed to lower some, the mortality and some degree of morbidity, but it's the longer term risk of infection that becomes tremendously important, and is what is creating a tremendous burden. And it's not just the neurologic, the fatigue, the problems with POTS and other things, as well as some of the vascular stuff, but it's things like blood clots, it's things like kidney disease, it's things like diabetes, strokes, liver disease, and all the disabilities. Those things are far and away, they're not the elephant in the room, they're the Tyrannosaurus Rex in the room. And most of us don't emphasize it, or don't understand that we should emphasize it. And I think that you want to keep yourself from being infected because you don't want to get sick acutely, but more importantly, you don't want to run into chronic infections. And many people who have problems long term don't have very severe infections. So be aware of the fact that the emphasis is don't get infected, don't get reinfected, get your symptoms investigated, and be aware of the fact that there are long-term implications to COVID infection, particularly if you get reinfected.
Yeah, I couldn't agree more. Just to recap, so we are in a different phase of the pandemic now, where less people are having severe symptoms with their initial COVID-19 infections. less people are ending up in the hospital and ICU or dying from the COVID-19 infections. However, we are now in a phase of people developing chronic disability from their initial infections, including developing new chronic illnesses. And this is having a direct impact on our decreasing life expectancy. And this is across the globe. So thank you very much, Dr. Kasza. We're now going to take some questions from the audience, if that's okay with you.
Certainly.
So many of my friends think the risk is low because they're in their 20s and 30s and healthy. Can you recommend some resources I can use to show them that they are still at risk?
I think that, just, specifically, I can't think of anything off the top of my head, but I think that if people actually talk to folks, just talking to people who've had COVID infections, and just ask them, or if you notice things that maybe they have some difficulty with their memory, maybe their energy level is not as good, and just get curious and start to read. Even there's some very good. There's a gentleman by the name of Ed Yong who wrote a number of articles for The Atlantic. If you look up some of the work he's done, he did an excellent review on long COVID for the layperson that actually really helps people to understand what exactly is going on. A lot of the stuff that I'm familiar with is it's pretty technical. It's pretty technical stuff. But Ed Yong did some very good writing. There's a few other people that have done excellent work as far as just look up articles on long COVID and sort of post-COVID, as we call them, post-COVID sequelae. And there's a number of people who've written some certainly very interesting articles. I think Scientific American has done one or two things. Those are the types of things that will at least help people to understand the potential risks and the implications of getting infected, especially that your initial infection is not that severe, and yet they get symptoms. They get symptoms long term. I think that, like I said, the two again, just to reemphasize, Mr. Young, as well as Scientific American or any scientific type journal for the layperson, is actually very helpful.
Yeah, there's also excellent YouTube videos by Dr. Iwasaki, Akiko Iwasaki from Yale. There's that long COVID parallel journey, and that's an excellent YouTube video to watch. Do vaccines decrease the incidence of vascular events?
The answer is yes. How much? I think it's approximately in the order of 20 to 30%. The last time I looked. The thing with vaccines is that you will develop a certain degree of immunity, but that immunity is short-lived. It's typically, we're saying for there is this mild decreased risk in transmission, but the risk of serious complications, it's about 3 to 4 months, and the last time I looked, I think it's about 20 to 30%, although I could be wrong on the numbers.
Yeah. How long does the cardiovascular risk stay high after COVID infection, and when is the highest risk?
Sorry about that. I'll just repeat what I was going to say. The risk exists for at least a year. It probably goes for longer than that. The biggest risk is in the first month, and there are some components of the vascular risk, like clotting events, that may be as high as 20% the baseline, or for people that have not been infected. The risk is significant, and you have to pay attention to it. And the risk of infection in and of itself affects the other cardiovascular risk factors as well. So it's not just a Newtonian thing where you can sort of go A plus B equals C. It actually becomes quantum, where potentially you're talking about a multiplication factor and perhaps an exponential factor.
Thank you, Dr. Kasza. Given the length of your career and the clear depth of your knowledge, can you offer other doctors some tips on how to approach administrations in their regard to embracing universal masking in healthcare settings?
Oh, brother. It figures that the particular individual asking this question would want to drop this nuclear bomb in my lap. I think, as far as I'm concerned, and I've tried to do this. I've tried to raise alertness and the risk of things. I've tried to bring up the fact that, the elderly are the ones that are most at risk, people with multiple medical conditions, people that are immunocompromised, people that have had multiple infections, and that masking, along with other things, will significantly reduce the risk. The biggest thing that I think people need to know is that hospital-acquired COVID infections potentially carry a 10 to 15% in-hospital risk of death. And if you catch a hospital infection, it is possible that your 1-year risk of death is as high as 25%. All I can say to the question that was asked is it's persistent lobbying. You try to bring things to people. You try to spread it out as much as you can and quietly go in the corner away from everybody else and scream occasionally when you get frustrated, and just realize that, it's really one baby step at a time. But again, I'm going to just emphasize that issue about hospital-acquired infections. Hospital-acquired infections are not a simple situation. It's not benign. It's a serious issue, because many people that are in hospital, their immune system is not entirely normal because they're dealing with something else, in terms of an infection or other medical condition, or they're having surgery. And then to have to deal with a nasty infection on top of it, it's not a good situation. So I think that alone, to bring down the risk of infection, is quite significant. And that's why it's my feeling that in a healthcare setting, where you've got vulnerable people all over the place, I think a universal masking policy is not only appropriate, it is good medical care. You're not doing any harm. You're exercising duty of care, and you're utilizing the precautionary principle, which, by the way, our engineering colleagues do a much better job of than we do in medicine.
Yeah, I could not agree more, Leslie. We need to be doing more, right? People always bring up the risk of heart inflammation or myocarditis post-mRNA vaccine. Can you comment on this?
Oh my God, this is another one that this is another nice, easy question. Let's be very clear. Is there a risk of myocarditis, which is heart muscle inflammation, or pericarditis, or the lining around the heart inflammation after an mRNA vaccine? Yes. The risk occurs both with the Pfizer vaccine as well as with the Moderna vaccine. Because the Moderna vaccine dose is higher, the risk is higher. To put it in perspective, from what I saw about the initial dosing, the risk is highest in the 16 to 24, 16 to 30 age group. And the other thing is that what has happened, and we kind of fell into this, is that when you gave it 3 to 4 weeks apart, that risk went up, was higher. In Canada, where we typically gave the first 2 doses 6 to 8 weeks apart, the risk came down, but it certainly was there. It has something to do with young men and their testosterone levels. I'm not smart enough to understand any of that. And I think that if you compare it, across the entire population spectrum, you're looking at probably a several-fold increase in the risk of heart or heart lining inflammation with a COVID infection as opposed to the vaccine. Now, if you look at the highest risk group for heart muscle infection, for heart muscle inflammation, with the vaccine, even in that group, the COVID risk is higher. I just saw a paper that actually was released, I think it was yesterday, from the European Heart Journal, maybe it was a couple of days ago, where the booster dose is significantly lower. It does exist even in young men. This is a third or more dose, but the risk goes down significantly as well. And the interesting thing is that in young women, it's like 1 in 500,000 doses, which is extremely small. Now, it's not that small initially in the initial series, but in the booster dose series, it's pretty low. It exists. It's a real thing. But the thing is that the risk of COVID infection is, it is greater. The other thing that I think is really important, and excuse me if I mess this up because this is not my area of expertise, but once you get a vaccine, for 10 to 14 days afterwards, the immune system is working to bring you to the highest level of protection. Because SARS-CoV-2 is so infectious, particularly with many of these new variants, it is very possible to get an infection in that 10-day to 2-week time period. And people may ascribe a complication to the vaccine when in fact it's the actual viral infection that's the problem. Now that's difficult to tease out. And it's one of the reasons why the American, Vaccine Adverse Event Reporting Service is a challenge, because a lot of that is not sort of monitored and peer reviewed. So those are the types of things that I think you have to keep in mind. Now, having said that, I have written a couple of vaccine exemptions. One was myocarditis related. The other one was for an entirely different reason, related to an immune event. So, yes, I'm very pro-vaccine. I still am very pro-vaccine. But I also think you have to evaluate things on a case-by-case basis and get some help, particularly since I'm just an old heart doc and I need the ID folks to help me lots of times.
With folks like that, I'm recommending they get the Novavax vaccine, which is a non-RNA-based COVID vaccine. They had reactions.
Yeah, and I think I think even with Novavax, there is a risk of myocarditis post-vaccination. I think it's the same or lower as in the mRNA vaccines, but don't quote me on that.
Is it true the risk of cellular necrosis from myocarditis from COVID infection is higher than the risk of transient inflammation of little or no risk necrosis from myocarditis from SARS-CoV-2 vaccine?
Any viral myocarditis carries, as a general rule, carries a much greater risk of significant heart muscle damage than the risk of transient inflammation, with fairly minimal risk in patients who've received a SARS-CoV-2 vaccine. Yes, absolutely.
What is POTS? Who gets it and how is it treated?
POTS stands for postural orthostasis tachycardia syndrome. It has numerous causes. There's the neurologic cause. There's it's often related to medications, and it could be nutritional. Postural orthostasis tachycardia syndrome, in the context of sort of a post-viral or post-COVID infection, is not that uncommon. We usually define it as a drop in blood pressure with an increase in the heart rate above 100 beats per minute, or a 30% increase in the baseline heart rate if people have been standing up for 10 to 15 minutes. It's a challenge at times to diagnose and to treat. This is one of the cases where numerous additional investigations need to be done. I think Obviously Holter monitoring is useful, a cardiac ultrasound to make sure that the heart structurally is normal. You obviously want some blood work, because one of the often missed but not insignificant causes of tachycardia could be a low hemoglobin or a low blood count, as well as high thyroid, a high thyroid reading or hyperthyroidism. And you can use something's called a tilt table, which is a fairly involved test that you have to have in a hospital, where basically what you do is you take people from lying to standing, you tip them up almost in a standing position, but strapped to a bed, and just monitor their heart rate and blood pressure. You can do it sort of naively or with no additional medication, or you can use some additional medicines. I actually think, and some people from Great Britain, including the brilliant GP Claire Taylor, as well as my even more brilliant cardiology colleague Ray Duncan. They often use a 10 to 15 minute lean test, where you have people stand up and you just monitor their heart rate and their blood pressure for 10 to 15 minutes. That's usually enough to give you an answer. It's quite common post-COVID. It can certainly be associated with a lot of the neurologic stuff, where you have brain fog, you have difficulties with, picking things up. You can have some numbness and tingling, a bunch of other stuff. How do you treat it? It's basically treated initially with, lots of salt and water ingestion. You try to control the tachycardia either with what we call beta blockers. There's another drug. This is off-label. It's a drug called Lyncora, which is an interesting drug because it just inhibits the sinus node. And the funny thing is, you'd think, well, you're just affecting a pacemaker of the heart. Why does that affect the rest of the body? Well, the body's not just the heart. So the autonomic or involuntary nervous system gets affected. Many people who have problems with changes in their blood pressure can also have problems with their vagus nerve. And there's a number of problems. The vagus nerve has a whole host of symptoms associated with it. It can be affected autoimmune wise. It could be direct infection. There's effects on your gut. There's effects on a whole bunch of other things. And that can often be associated with POTS as well. So, it's one of those things where you approach it and you think about things to support the blood pressure. There's some other medicines you can use, some of which unfortunately will increase your blood pressure. So oftentimes what happens is that you may have to use a combination of medicines to try and control the symptoms of POTS.
That's really interesting. Is there any evidence that people should take aspirin 81 milligrams for cardiovascular prevention after having a COVID infection?
Another easy question. I think that if you have no risk factors, my answer would probably be no. But unfortunately, many of the people I see are older. They have other cardiac risk factors. And if they were not, I think if you have high blood pressure, high cholesterol, diabetes, or some combination thereof, it would be something certainly to think about. Aspirin is what we call an antiplatelet drug. So platelets, which are the blood cells involved in blood clotting, are inhibited by aspirin. It's irreversible, and the platelets last on average for 7 days. So I think for people that have associated risk factors, I think it's reasonable. There is a group, mostly out of Great Britain and South Africa, who've looked at the possibility of microclots in people with, long COVID type symptoms, and they've used 2 antiplatelet drugs, so 2 drugs that affect the platelets, and they use direct anticoagulation. So you've got 3 different anticoagulants. They've had pretty good results with it. I personally, I guess I'm just getting old. I'm getting gun shy in my old age. I would obviously be concerned about the risk of clotting, but I think it's still something to think about. The trouble is that before you do something like that, you need very specialized investigation. That's a long-winded way of saying, if you don't have risk factors for heart disease, I don't think so, but it's not as clear as it's not clear, and anything I've seen suggests it's not the case. But I think if there's risk factors involved, I think certainly you've got to think about it.
We have a live question from Bob Mackin.
Yes, can you hear me?
Yes.
We can.
Okay, good afternoon. I was wanting to find out about incidents of minor viruses that target the heart in this COVID era, and wondered if someone who has had COVID maybe a year or 2 years prior, is that person more susceptible to temporary and minor heart ailments, such as a virus that causes palpitations?
That's a tough question to answer. We know that SARS-CoV-2 does cause some degree of immune dysregulation. The most honest answer I can give you is I don't know. The wild speculation on my part is it would not surprise me. And the difficulty is that making a simple statement as you've just made is extraordinarily difficult to prove. But I think if you're in a situation where you have a viral infection that affects your immune system, makes you prone to other viruses, and potentially symptoms from that, it's certainly a possibility. I won't say it's factual, but it's certainly a possibility. But again, this is pure speculation on my part.
Either anecdotally or if there's any journal publications, are you seeing or hearing of an uptick of those kinds of minor ailments, such as the palpitations, at this time?
Well, I'm seeing an awful lot more people with palpitations and arrhythmias, I can tell you that. What specifically are they? Do I think they're associated with COVID infections? Yes, absolutely, I do. It's difficult to prove causality, but I think it's more a case of clinical experience and just being aware of things and observing. What the actual cause of it is, it's difficult to speculate. There could be any one of a number of things. But
Okay,
yes,
thank you.
we're certainly seeing a lot more people with the complaints of palpitations.
That was Bob Mackin from the Breaker News. I think they're... Oh, does Dr. Kasza ask patients about a COVID infection history?
Absolutely, completely, 10,000% yes. And I'm especially careful in the patients of mine or new patients that I see with stable heart disease who deteriorate. Recently, I've had to send somebody for urgent valve surgery who was stable, who almost certainly got a COVID infection, had a secondary infection after that, and his stable valvular heart disease and his stable heart function both metaphorically fell off a cliff, got much worse, and he needed fairly urgent valve surgery, which necessitated him being admitted and having the surgery quite quickly. So absolutely, I ask in all cases. I've just learned over the last 4 years I have to ask people.
Yes, I mean, definitely. I'm telling my medical students now that don't forget the diagnosis of COVID. They're going to be seeing a lot of post-COVID, long COVID, and don't forget to ask that as part of the medical history. They're going to be seeing a lot of this disease in the future. Can you explain what MINOCA, minimally obstructive coronary artery disease, is and who is at risk?
MINOCA, or minimally obstructive coronary artery disease, occurs in people with symptoms that are typical of what we would call a coronary artery disease angina, which can be either a heaviness, a pressure, a burning sensation, shortness of breath, anywhere from your belly button to your earlobe, front and back. It's not just chest pain. In people that, if they've had an angiogram to look at the arteries that supply the heart, which is an invasive procedure, have no significant large coronary artery disease, but continue to have symptoms. And they may have abnormalities on other testing, such as nuclear medicine tests, a cardiac MRI, or or in a CT scan. It's thought often to be due to abnormalities in how coronary arteries respond to various types of physiologic or hormonal changes, and it's probably seen more commonly in women, but
Hmm.
it does occur in both groups. We're likely seeing more of it with SARS-CoV-2, COVID-19 infection, simply because the vascular beds that are affected by this endotheliitis we see are both large blood vessels as well as very small blood vessels, and there are certain things you can use to make the diagnosis. Um, it's not an easy diagnosis to make.
Hmm.
It's something that you have to do a lot of sort of very interesting studies, including what we call physiologic studies, where we'll inject certain substances in that we may do it during an invasive procedure or sometimes with a nuclear medicine procedure. But it's just something to be aware of. I think the the importance of it is this, that the risk of heart attacks and arrhythmias is not insignificant in that group, and they do need to be treated.
Thank you very much. What kind of support can regular people provide to members of their family or community who are experiencing post-COVID vascular issues?
The most important thing is listen to them and take their symptoms seriously. There's been far too much minimizing, gaslighting, ignoring of these types of symptoms, and the sooner people can pay attention to things, get them, get their family member or themselves some help, and get things investigated, makes a big difference. I think for people, for example, who have POTS, allow them, get up slowly, make sure they drink lots of fluid, they're well hydrated, add a little salt, just try to help them out when they can. And older folks who have problems with their blood pressure and heart rate, help give them a hand out of bed. If you need to get occasional home care for the really severe folks, get the help. Remind your family members that, particularly if they've had a lot of symptoms post COVID and they have difficulty even doing activities of daily living, to get their rest, take them seriously, and give them some grace and peace, and leave them alone until they can recover. There are some people with they're not infrequently people with milder symptoms, sort of post COVID. Some of those folks will recover, but we don't know what the long-term prognosis of a lot of this is. We're still quite early into this. If you take, for example, HIV. With HIV, the time from when you get infected to the time where you have full-blown AIDS, this is before the use of antivirals, was somewhere between 8 to 12 years. So we didn't know. We thought it was just a mild thing and it was no big deal until
Hmm.
we had this huge problem in the 1980s and 1990s. We're still early as far as what the long-term effects of SARS-CoV-2 are. We do know from SARS-1 that anybody who got infected with SARS, 10% of them died. And by the way, BC did a much better job with the management of SARS than Ontario did. And a big shout out to a certain retired Vancouver emergency room physician for that. And secondly, even those that survived, had significant health problems 7, 10, 12, 14 years afterwards. So we don't know what's coming. So the most important thing you can do for your family member or your friend, take them seriously when they have symptoms, help them out where you can. Thanks.
Yeah, I totally agree. Listen to your patient, listen to your family members. That's really one of the most important things. I don't think there's any other questions. So yeah, so Thank you so much again, Dr. Kasza, for joining us today for this live briefing on COVID and its effect on the heart. And thanks to our followers for listening today. And a big thank you to Carrie, our IT support person, for making this live briefing possible.
I would just like to say thank you to POPBC for inviting me. Thank you, Susan, for putting up with me and my half-Irish blarney. And thanks, Carrie, for your help on the IT stuff. And a big thanks to the retired Vancouver emergency room physician, la belle magnifique Dr. Filiatro, for inviting me to do this. Thank you. And thanks to all of you for coming and listening, because I think it shows commitment and your willingness to learn new things. Thanks again.
Thank you so much again. Really appreciate you coming on.
When your heart skips a beat, when your breath gets taken away, when you feel your heart racing, it might not be love. It could be damage from repeat COVID infections. Don't let COVID break your heart. Prevent infections. Use respirators, ventilation, and filtration. Because it's not just love that's in the air.